better.
We're so
All right, so today we have a very exciting guest. We have Dr. Julia Iafrate, who is a sports medicine ACGME fellowship trained attending physician at New York Presbyterian and Columbia Cornell. She's a team physician for the US ski and snowboarding team, so we'll definitely go into that and kind of talk about what it's like to be a team physician for professional athletes. And then she also has a specialized interest in dance medicine. So welcome, Dr. J.
Yeah.
Thanks for joining us.
Thank you for joining us. So Dr. J, go ahead and tell us a little bit about your educational background, where you're from, where you trained, so everybody knows.
Okay, so yeah, for those of you who haven't seen me in the news recently, I'm Canadian. I did my undergrad training at McMaster University in Hamilton, Ontario, Canada, and I graduated with an honors Bachelor of Science in Kinesiology. And originally I was planning to become an athletic trainer, and I realized very quickly that ATCs unfortunately have a pretty low glass ceiling, and I don't like being told what to do. So I decided I was going to go to medical school. But I took a year off first because I just needed a break. And so I took my MCAT, and then I actually moved to Kenya and lived in a mud hut in Kenya for 6 months. And that's where I did my applications for medical school. And for me, I had actually had multiple sports injuries when I was in college. And so I actually had been exposed to DO schools via my athletic trainer. In Canada, we don't have any DO schools. And he's like, I feel like that would be a good fit for you, because I was thinking I wanted to do sports medicine just based on all the injuries I'd sustained. And so I made a deal with my family, and I said, I'll apply to MD schools in Canada and DO schools in the States. And whichever I like best, that's where I'm going to go. And I ended up getting a scholarship and decided to come down to the States. And so I did my medical school at Midwestern University ASCOM campus, so Arizona College of Osteopathic Medicine. It was very hot in Arizona. And so I actually did my third and fourth year up in Ohio, in Columbus, Ohio, with like Ohio State and Doctors Hospital and Grant Hospital there. And then I did my intern year at St. Vincent Hospital in Indianapolis, Indiana. And I did that very strategically because I knew I'd get a lot of hands-on because they didn't have any fellows there. So I got a ton of hands-on procedures, which was good for me because I like global medicine, and I wanted to be able to intubate, be able to do central lines, all that stuff. And I knew at Mayo, there's like 80 internal medicine residents a year. So I figured I'd be a scut monkey. And then I did my residency at Mayo Clinic for the 3 additional years. And then I did my sports medicine fellowship at the University of Iowa, and then got recruited straight out of fellowship to come here to Columbia.
Nice. Here you are.
And yeah, so I've lived in like 6 states in 15 years.
Plus Kenya. Yeah. So.
Plus Kenya.
No, right. Yeah.
All right. So you kind of went into detail of what interested you in sports medicine, just, from your own background and stuff, but go a little bit more into kind of why exactly did you choose sports medicine, and how do you become a competitive applicant for sports medicine fellowship?
Sure. So originally, I played soccer, I danced, and I skied competitively. And so I had sustained 3 knee injuries and had 3 knee surgeries in 4 years during college. So I spent a lot of time in the physical therapy office and with my trainer. And I actually was treated after I had my surgeries with one of the orthopedic surgeons. And initially ortho was kind of the route I was thinking about going. And then actually a physiatrist started taking care of me for some of my issues that I was noticing afterwards, because I was having all these biomechanical problems, especially when I was trying to dance. And I was like, I kind of like this guy's job. Maybe I want to be a physiatrist. And originally, I was like, is it a podiatrist? Is it a psychiatrist? Like, I didn't know what it was. Right. Yeah, exactly. But yeah, so I really liked his job. So I kind of ended up going into medical school knowing I was probably going to do PM&R sports medicine, because to me, it made the most sense. I think like when you're for what I was wanting to do, and I love being on the field and I love like being involved in sports, in any way that I can. It just made sense to like really know the musculoskeletal system. Like you can't do surgery on the field. So no offense to my ortho colleagues, but like, so it felt like a good fit for me. And I like talking a lot, and I get really hangry in the OR if my cases go more than an hour. So none of that made sense to me. So that's kind of what drove me into sports med. And to be a good applicant, I mean, I had a long history of sports related endeavors, both as an athlete and then as a pre-athletic trainer kind of thing. And then I think because I knew I wanted to do sports so early on, it was really helpful because I started doing some research that was somewhat related to it. I joined AMSSM and ACSM very early on, got really involved. And then even IADAMS, which is the International Association for Dance Medicine and Science, because as a dancer, I was thinking like, dancers are athletes, why don't they get good care? And it was really making me angry. And so I was thinking, well, I could add that into my practice and make that part of what I do. Because when I was in med school, I didn't have any mentors that were doing dance medicine. And I also actually didn't have any female mentors now that I think about it. All my mentors were guys. So it was kind of a little bit of blazing my own trail.
That's amazing. You're like a sister after my own heart, because I majored, you really are. Yeah. I'm like, oh my God, this is my soulmate. I majored in kinesiology as well. And I danced my whole life. I minored in dance in college. And I danced competitively all the way to college. And people don't realize like how much of an athlete dancers are. They are so hard on their body. Some people are dancing 8 hours a day, every single day. I'm like, my feet today are horrible. I've had injections in my foot. Feet. Yeah, they're horrible, right?
Terrible feet.
So can you expand a little bit more about dance medicine? Because I think it's excellent. I love what you're doing. And I think more people need to hear about it.
Thanks. I mean, so dance medicine, performing arts medicine, they kind of get lumped together. And some people really do sit more on the performing arts side. They like working with theater. They like working with musicians. And then there's more the dancer side of things. And I think when people think dance medicine, they think ballerinas only, and that's not the case, right? So I deal with a lot of hip hop dancers because that's what I danced when I was in college. That's the crew I was with. A lot of salsa dancers or like Latin ballroom dancers. And then, yes, the ballerinas, the contemporary, the modern, all of those people too. And it's a lot of the injuries are what I consider similar to a lot of the running injuries because they're repetitive overuse
energy,
right? And these people have been dancing usually very early on. And so they never really developed like the motor skills to kind of support the flexibility that they have to have. And so you see these chronic hip injuries, these chronic knee injuries, these chronic ankle injuries that never really get fixed because you're told, don't tell your teacher about it. You're going to get kicked out of the production or, you're fine, just walk it off, and there's this concept in dance of you're supposed to have pain. You're not doing it right if you don't have pain.
Suck it up, right? Yeah.
Suck it up.
Suck it up.
Yeah, exactly. And so for me, I think being able to do dance medicine is not only about like taking care of the dancer physically, it's also taking care of them kind of on that mental level and that psychological level, and realizing that the perfectionism in dance is actually somewhat dangerous to them. A lot of the time because it makes them cover up a lot of their issues and they don't register kind of what's happening to me. And so they end up with, I use this term stacking all the time. They end up stacking injuries on top of each other. And then by the time they actually finally come see you, it's like, oh my God, where do we start?
Right. Very much a kinetic chain problem.
Oh yeah. And I think from a kinesiology standpoint, that's what I always think of as the biomechanics. And so I think that's why I can really, like my dancers feel like I get them because I know the injuries. I've had the injuries, I've been there, and they understand that their turnout is not the same as, a normal person's turnout. They go far past it. So like, exactly. It might look normal to, exactly. Or like, my break dancers, if you're doing head spins, nobody else does that. Like that's not a normal movement. So like neck injuries happen in dancers and you kind of forget about those things. So it's been really cool. Columbia didn't have a dance medicine program when I started here. And so that was a big thing that I wanted to bring to the practice is I said, I really want to focus on working with specifically dancers. One of my colleagues does do some performing arts work, but I really wanted to work specifically with dancers.
I think in New York, that's perfect too, because that's like the Mecca, right?
Yeah, exactly. That was part of the reason I wanted to come here. I was like, Minnesota was great, but.
Right.
Yeah.
Well, that's perfect. All right. So you also mentioned that you are a team physician for the U.S. ski and snowboard team. So talk a little bit about how that happened. How do you become a physician for, the U.S. team or professional athletes? And because you always hear you know, we have medical students that message us, oh, I want to be the team physician for the Dallas Cowboys, or
Right.
you know,
Yeah.
the Heat or something. So go also in a little bit of detail about like the pros and cons of being a team physician, kind of some of the stressors that you have. Yeah.
Yeah, so some parts of being a professional team physician are very political, and that I did not realize when I first got interested in it, especially at like the NBA, NFL, like those levels. However, when you work with Olympic sports, less political. And so part of that is like you have to be invited into the club. So when I was a fellow, I did my fellowship at University of Iowa, working with D1 college kids, which I loved. That's why I went there. I really wanted to do some D1 college coverage. And so I got amazing coverage experience, but obviously no skiing coverage experience. But Derek Hall, who's one of my mentors, and oh my gosh, why am I blanking on names? Britt Markison. My gosh, sorry, Britt. Britt Markison was my fellowship director, and they both work with the U.S. ski team. And I'm a very strong skier. I've been skiing since I was like 6. And so when they traveled with the team the year I was doing my fellowship, I said, "Can I come with you?" I paid my way, and I went with Derek to Oslo, Norway, with the ski team.
Cool.
Yeah, which was great. And so it was great because it was me being on the field still. It was still a really educational experience, but I got to ski. And Derek's a terrible skier. I'm totally calling him out here. So I was actually more useful in some situations, but it depends on which team you're with. If you're working with like the Nordic combined team, you know, you're not skiing down that giant ski jump, and that you're not, you know, you can cross country ski. That's not that hard. They're way better at it, obviously, but you can get there. But if you're working with the alpine team or the like snowboard half pipe team, then you have to be able to get down the hill to them. And the faster you can do it and the more efficiently and not hurt yourself, the better.
Right.
So,
that's something I wouldn't even thought about. Right. Yeah.
Yeah.
It's very
Yeah. So with US ski and snowboard, being a good skier is helpful, but it's not, I guess, necessary. But you have to be invited into the group. So you have to have been in practice for a while. You have to have letters of recommendation from other doctors that think that you'd be a good fit for the pool, because they do a ton of coverage. Like they have competitions like every weekend, basically. You're supposed to be a US citizen. So I'm the only one who's one of their team doctors who's not a US citizen. They made an exception for me. I was like, come on. Cool. I'm not a spy. I'm not a spy, I promise.
Right.
I'm not selling your secrets to Canada. So that's how you do it with them. But in terms of like other professional sports, a lot of times it's the doctor's office or the hospital that is the team physicians or the medical team actually pays to be part of that medical team.
A lot of people do not realize that. A lot of money to be honest.
No, exactly. They pay a ton. And you kind of want to go like, okay, so everyone else that's working here is getting paid, but I'm paying to work here. That's kind of weird. Like,
right. It is. And it's very time consuming.
Very time consuming. And a lot of these athletes are very high maintenance. No offense to you guys.
Yeah, no, that's
you
true.
You know who you are.
Yeah.
They are. And that's fine. This is their livelihood. I get it. So I think a lot of the times it becomes like, if you're very early on, you want to join a practice that already has an established relationship, if that's the level you want to be at. I didn't care so much about covering like NFL or NBA. I enjoy those sports a lot and I would do it down the road. But for me, I wanted to work college, and like even with Columbia, like I do a little bit of work with the college teams there, but I work with Barnard, you know what I mean? So a lot of the dance companies in New York as well, and then professional on the Olympic level. And that was just a good mix for me. But I think creating those relationships, that's how you get involved with these things. And I guess, unfortunately, money doesn't hurt. Having, if you're going to do it as an independent physician, you're going to have a hard time, I think, unfortunately. And that might change, but for now, that's the situation.
No, and I think that's excellent advice. I often get asked, people who are like, oh, I want to go into sports medicine. What do you do? And I tell people like, well, what do you want to do? I'm like, do you want to cover a D1? Like, I went to a program that covered a D1 school. It was amazing. But I also realized when I was in it, I'm like, this isn't for me long-term,
Good.
And that's fine, but I'm like, if you want to do that, you need to tailor your fellowship and even your residency if you can. I tell people all the time, I'm like, if you want to do musculoskeletal and be amazing, I'm like, go to the Mayo Clinic. If you don't mind living in Rochester, I'm like, go live
Vegas.
Jonathan. I say, go to Iowa and try to go there and learn from a Derek, because you're going to learn from the best and cultivate those relationships now.
Exactly. Yeah. It's
key to relationships. Yep.
Yeah.
Network.
A lot of what I've achieved has been because I was good at networking, and I was okay with living in Rochester, Minnesota for 3 years because I knew I was going to get the best training for what I wanted to do. And same thing with Iowa. People would be like, "Why are you like Midwesting it up?" And I was like, "Cause this is where
the best.
Yeah, these are where my guys are. It is what it is."
True.
And like I said, I didn't really have a lot of female mentorship, but I had a lot of male mentorship, and most of them were Mayo Clinic trained at some point, and then had kind of dispersed wherever. And I knew I didn't want to stay at Mayo, so I didn't want to do all my training at Mayo, because then you only learn one way of doing things, and that is awful when you're going into practice somewhere else. You need to be a little bit, flexible, have a little bit more exposure to different ways, exactly, so that you can create what works best for you.
No, I totally agree. Absolutely. So you do a lot of ultrasound, which is amazing. Sheena and I love to do ultrasound. You've done some educational videos for butterfly. I use the butterfly a lot. I actually used it in an injection in the hospital the other day. They called me to come and do, and Sheena uses the Lumify. So what advice would you give to medical students and residents listening in, or even attendings who want to get better at ultrasound and haven't had that experience in their training? What would you recommend for them?
I mean, a big thing. So something that was taught to me when I was in grade school even was not the concept of practice makes perfect, but the concept of perfect practice makes perfect, because practice just makes permanent. So if you're like, I'm just going to teach myself ultrasound, good luck, because it's 50 shades of who knows what. And I think until you know what normal looks like, it's really hard to appreciate what's abnormal. Absolutely. Even, like I said, I did my residency at probably the best place you can do, get MSK ultrasound exposure. And still, even when I went to fellowship, I'd be like, Derek, I don't know, there's this thing, it's weird, it's not normal. I know that, but I don't know what it is. And he'd be like, Iafrate, come on. And it is, it's a craft that you're constantly building on. So I think if people want to get the exposure, I mean, the AMSSM videos that they have are really, really great, but you have to know the anatomy first really well, because otherwise you cannot relate it back to what those images look like. If you can take a course, even if it's a weekend course, just to kind of get some exposure, that's good. And then, I mean, the ESSR, all the books are helpful, but I think videos and seeing like the fluidity of the movement is way, way better. That's why I did that video series for Butterfly.
It's great.
Because it just gives you like, oh yeah, okay, I see how when you move from here to here, that's where you see these structures show up. Because still images, you're like, I don't know where we are right now. And learning how to label properly is also very important. That's something I really push my residents, like, show me where you are. Orient me, because this could be anything,
Right.
So I think those are really important. And then working with a buddy, practicing on each other. Practicing on yourself's fine, but it's hard. And you can't be like, is this right? Do you agree with this?
Right.
Yeah. Does that look like a ligament?
Yeah.
So even those of us that are, fairly well established with our practice, we do the AMSSM Advanced Musculoskeletal course every year for ultrasound. And so I was actually supposed to teach at it this year, but of course it got canceled, so that hopefully next year we'll do it. And then beyond that, we have a group called like Teach the Teachers, where we're all teaching each other like new stuff that we found, because it's constantly changing. The machines keep getting better, so that means you should be able to get better too. But initially it's all about practice, but practice smartly. Don't just like be like, oh yeah, I think that's what that is. Make sure, go back, look at the books, look at the textbooks, look at the anatomy, orient them. There's a good cross-sectional area textbook from Cienka and Patel.
I'll post it on there. Yeah.
Okay.
I'll post it on
them. Yeah, because I mean, like, Jacobson's book's amazing. Like, don't get me wrong. There's a lot of great books out there, but this cross-sectional one's kind of helpful because they drew little drawings to make you like go like, oh yeah, that's what that is. That makes sense. And I think that helps orient people a little bit. And that's been really big. And I try to get my residents to just practice, take pictures, take videos, show them to me. Let's run through this, as opposed to you just convincing yourself that you think you got it.
No, I think that's like knowing anatomy is huge. You have to know your anatomy before you're going to draw an ultrasound on it. And I remember Sheena and I, we used the AMSSM videos. We found it. We're like, oh my gosh, this is gold. Like it's free. Amazing. It's part of your membership. Yeah. So we would like have the video. We would have our anatomy textbook. We had each other. And we're like, pause, go.
Yeah.
Like, oh no, press pause. Yeah. Play it again. Exactly. Rewind. Press pause. Yeah. And that's exactly.
Yeah. And like, you know, it also depends on how good a machine you have. It's, you know.
Yeah.
But
that helps.
Understand what normal looks like first. Then you can say, that's not normal. I might not know what it is, but that's not normal.
And that's with anything, MRIs, X-rays, right? Like any imaging. Yeah.
Exactly. Anything we look at, we have to know what normal is first.
Absolutely. And Sheena says this all the time, like for residents and medical students, like if you order a test, an MRI, look at it yourself. You don't know. We've countless things that we've seen that because we have the advantage of examining the patient and having an idea what's already wrong where the radiology this doesn't. So I'm like, look at every single image. I cannot stress that enough that you order because you will learn so much from it.
Exactly.
Oh, very good. Okay, we can switch gears a little bit and talk about how you ended up working at the front lines of in New York City fighting COVID.
Yeah. So March 13th, I think. I actually went skiing for a weekend in Vermont and came back luckily on Sunday because they closed the mountain actually. And I was like, oh, this could be bad. And then on Monday, I got a call and they're like, we're closing our clinics down. No more procedures, no more seeing patients in clinic unless it's urgent. No more surgeries, like everything's shut down. And you're going to help workforce health and safety. Initially, that's what our department was doing. So we were just kind of being like call in telehealth for the workers of New York Presbyterian Hospital. And I did that for about a week, which was fine. Don't get me wrong. But I'm also very much a little bit of a go-getter and I was getting kind of antsy. And so when they asked for more volunteers, I, volunteered right away. And part of the reason I did that is because I didn't want my colleagues to have to go if I could help it, because some of them are older than I am, have kids, are a little bit further removed from their residency training. Whereas for me, I at least had ER training from my fellowship because my sports med fellowship was a primary care sports med fellowship. So I had some ER training. I remembered my ICU training because I had amazing ICU training even in my intern year. I could drop central lines with my eyes closed, honestly. So I volunteered to go to the front lines because of that. And because I'm just one of those weirdos that likes running into the fire, I guess.
You gave me chills, girls.
Oh my God. My family was like, why? Come back. But, it just felt like the thing I had to do. It was, my way to provide, whatever I could do. And so I volunteered and we got some education, like we got all these videos to remind us how to manage a ventilator. And so I ended up joining a couple of the other surgical teams that, have run SICUs before. But I was the only person from my department initially. And then one of my colleagues also joined a little bit later, just in case in case I got sick and we needed an extra person. But it was really cool to see how much everyone kind of banded together, worked together. I mean, New York got hit hard, right? Like we did not look good for a long time there. And so it was really great to see how much the nursing teams and the physicians and the physical therapists, everyone just completely changed roles, put everything onto their heads and just really worked as a team. And it was really nice to see. I mean, terrible situation, but so good to see. And the way we made it work was almost like a pyramid. So you had like your residents still kind of covering in whatever fashion they were, divvied into. So some of my rehab med or PM&R residents were in the ER and some of them were in the ICU. And then on top of them was like a supervisor resident, so like a senior resident or an off-service attending. So I was functioning kind of like a senior resident in some ways, which makes perfect sense. And then above that was like an overseeing attending. And this was either an ICU or critical care attending, or even a fellow, crit care fellow. And then on top of that was like the top ICU attending. And the reason we had to do that is because we had to turn our ORs into these little pods of ICUs. And so I had a pod of 4 patients that I was taking care of with a resident. And so each pod had an attending covering, and then 3 pods had another attending on top, and then the entire half of the wing was another attending on top. And that's how we made it work. And it was confusing, but it worked. It worked because I can manage a lot of regular stuff, but like one of my patients, we had to put a central line, or not a central line, excuse me. We had to put a chest tube in, and I was like, I haven't done this in a little while. So like one of the surgery residents and I put a chest tube in, and I probably wouldn't have been like super stoked about doing it on my own, but at least I kind of remembered. But the fact that you still had the support there, so yeah, it was kind of like being in the trenches together, and everyone really respected each other. And it was nice. It was nice to hear the claps, but when you're in the hospital, you can't hear the claps because you're still working. So you're like, theoretically, I know they're clapping. Thank you. It was cool. It was fun, and it brought me back to residency. It brought me back to some of my training, and it was actually a really overall good experience in just a very terrible time.
Right. Yeah. I think a lot of people don't realize like that PM&R that we do that year of training and how important it really is.
Oh yeah. Internal medicine's huge. I mean,
it's huge in PM&R. It really is.
It's huge. Yeah. And it makes you a better physician, obviously. Like, so I think it's important. I laugh when people are like, oh, PM&R, I don't like taking care of medical problems. I'm like, well, it's all medical problems.
Right.
You 100% are trained in this. So it just depends on how removed people want to be or claim to be or whatever. But yeah, I never was like, oh shoot, I have no idea how to do this. And if I would have felt like that though, I know I would have had the support.
Yeah.
And I think, I'm sorry.
How long were you doing that for?
So about 2 months. And then I know we're going to talk about it in a second, but then my green card got denied, and so I couldn't work anymore. So I just got like kiboshed for a little bit.
Wow.
But yeah, so it was about 2 months, but I wasn't working every single day. I was working because I was still doing telehealth for my sports med patients, right? So I was doing 2 days of telehealth, and then like 3 to 4 days in the either the ER or the OR ICU.
And you brought something up about doing a primary care sports medicine fellowship, which is what I did. And you do get it's a lot of primary care that you, I'm like, but like you really, I'm like, I can treat this. Like, I can suture, like it's not, which is kind of perk. It just helps you in your practice, I think, in the long run.
Yeah. For me, I felt like my PM&R knowledge was so good. My MSK knowledge was so good that I was like, I don't need another year of that. I need a year of how do you manage STDs in college athletes? Because I don't remember.
Because it happens. Yeah, right. Because it happens.
Don't do that. Stuff like that. And just, again, global health, because I like to go volunteer. I worked while I was a resident, I went to Nepal and did a month-long rotation there. So just having those skills kind of helps you, MacGyver things if you need to where you are. Because sometimes you're the best doctor. Even if you're not technically the right doctor for it, sometimes you're the best option. So.
Yeah, absolutely.
Yeah.
All right. So you mentioned a little bit, that you're from Canada, and some of our viewers may have seen you on the news, talking about, obviously you were taking care of these patients in the ICU and ER, and you were applying for a green card. Unfortunately, the application got denied, which is ridiculous. Like, I do not understand that at all. So kind of go into a little bit of detail about that, what was that like, and kind of give us an update on what's been going on.
Yeah. So my immigration status has been like an ongoing thing hovering over me, I think, since I started medical school here, because, you come in on an F1 visa, and then it has to, in order to be allowed to do your intern year or your residency, you have to transition off of the student visa and go onto a work visa. And then that work visa needs to get carried over to each place that you train at. And like I said, I bounced around a lot. So that thing kept getting switched over. And it was a lot of times I was the first foreigner that they had. And so they're like, we don't know how to do this. And I was like, well, let's figure it out. Because and then when I came to work at Columbia, I said, I'm going to have to apply for a green card soon. And we were like, yeah, it'll be fine. And then when we did the application, we submitted my application last year, like well before COVID. It had nothing to do with COVID. It was just, I need to keep working. This is an employment-based green card. It's in the national interest of the country to keep me here. And so we never really thought it wouldn't go through. There was no reason for us to think it wouldn't. But, you know, you do have to prove that you're an expert in your field when you apply for the type of green card I applied for. And that's really hard 2 years out of fellowship, right? Like, but you have to kind of, right. But you have to combat the imposter, right? Yeah, and you got to combat the imposter syndrome, because in my head I'm like, no, I'm not that good. Like, look at Jay Smith, there's Madera Call, there's John Finoff, and I'm thinking all these people that are my mentors. But like, yeah, they're also they're the experts. They're like the experts of the experts. But I still count as an expert. I am still looked towards, and so registering that actually was really hard for me at first. But I was like, oh yeah, I guess I'm pretty good at this. Like, yeah. But if you don't have a lot of research, which I don't do a ton of research, I do a ton of teaching, but research is not where my interest lies. So it's harder to like show something for it. And so at first I was like, is that going to be a problem? He's like, absolutely not. Look at where you're working. Look at what you do. We're fine. But when they closed down the USCIS and then that travel ban or the immigration ban went into effect on April 20th, 8 days later, my green card got denied. And so I have no idea for sure if they were related in some way, shape, or form, but I feel like I fell through the proverbial cracks.
Right.
I mean, it's, and the wait time is extraordinary for these green cards, like 18 months, 2 years, 3 years, even for like marriage visas, because everyone's like, you should just get married. And I'm like, I don't want to do that.
Right.
But even if I did, it would still be the same problem. It's just a different version of the same problem.
Right.
So it was really frustrating, because here I am volunteering, working in the place that I consider home. Like, I call New York home. I go to Canada to visit my family, but I don't call Canada home anymore. I've lived in this country 13 years. Like, this is my adult life.
Right.
Yeah. And so I'm working, and then I get this letter in the mail, and I open it thinking, here's your green card, congratulations. And it was like a 4-page denial. And I just like, sat on the ground, and I was like, ugh! Like, I didn't know. I didn't know what else to do. I had like this rush of emotions, and I was like, are you bleeping kidding me right now? Like, what?
It's crazy.
Yeah. And so I sent a text to our chief financial officer of our department and my boss and my lawyer. And I'm like, what do I do now? What is this? You know? And then I posted something on Instagram, and Chris Cuomo saw it, because he follows me on IG. You're welcome. And so he sent me a message. He's like, is this for real? And I was like, yeah, I got denied. And he's like, okay, can we have you on CNN? And so that kind of spearheaded it. But in the background, my lawyer was already talking to the USCIS and asking for a supervisor to review it, because they had closed down, there was no supervisor review. So the denial should have been reviewed by someone, and there was nobody to review it. So he asked for a supervisor review. They had actually agreed to do the review the same day I did the interview. They said they'd do it like right before I went on the air. So it's not like Chris made them do it, but I think the media exposure did help people recognize, like, hey, this is kind of a really weird situation.
It's kind of a messed up, right? Yeah.
You know, we're calling these people healthcare heroes, and then we're saying, but you don't get to
you can't stay here. Yeah. You can risk your life on the front line, but you can't stay.
Yeah. And like, I'm not stealing anyone's job. I already have a job. I've already been doing this job. Like, I've stolen 0 jobs from anyone. So
you're teaching.
And you know, if there's someone else that wants to go to the front lines, like, where are you? I was like, let them go. But I'm here. Here I am. I'm offering my services. So free of charge, you know? So yeah, it was really traumatizing, because you're going through the stress of taking care of COVID patients. I can't touch any of my friends, my family. Like, I stayed far away from everyone, because I figured I probably had it. And then to get that, I was just like, no, you know, it's just like, oh, it was a punch in the gut.
Salt in a wound, right?
So I was salty afterwards. It made me really frustrated.
No, that is, and I'm glad that it has worked out. And Chris Cuomo, thank you for you for following her.
Appreciate it. He's like my little guardian angel, apparently. my little Italian guardian angel, I guess. But yeah, no, it was, everyone, for the most part, people were really supportive. Some people were like, you stupid illegal, and I'm like, I'm not illegal. Like, I'm supposed to be here. You know? So I'm writing an op-ed piece now about like immigration in medicine, because I feel like a lot of people don't actually understand what it is and what we go through and what we have to do. And, you know, there's all these people
please share with us.
Yeah, like, just do it the legal way. It's like, yeah, I am. Like, and still, this is, you know.
Oh my gosh, yeah.
Don't ever read the comments, right? They always tell you don't.
Oh, I know, and I
Oh.
did.
Yeah, I'm like, I'd be so tempted, but I'm like, my blood pressure, I can't let them take this energy.
Yeah, I got a couple marriage proposals out of it too.
Oh, see, yeah. Okay, well,
I was like, no.
let's talk about that.
I was like, my poor nurses, they were like, people keep calling our office to marry you.
Oh, wow.
And I was like, just delete those. Don't tell me about those.
Do that.
Yeah.
No, let's go ahead and open up our questions for our viewers. We have some on here. Okay, George is asking, if you want to stay in academics post-fellowship, is there anything you should do to make yourself more marketable for jobs?
Yeah.
I'm assuming it's sports medicine.
Yeah, I think it depends on if you do like teaching, having a lot of teaching endeavors that you've done, whether it's lecturing at AMSSM or teaching medical student interest group, like those things really matter when it comes to academic medicine. If you like the teaching aspect, if you want to do research, obviously you have to have the research component. If you're like, I'm just going to stick to myself, probably academics is not the best option for you. I think, like I said, networking is huge. AMSSM and ACSM are gold mines for meeting people, especially people in academic medicine that want to hire you. So if you're not going to those, you really need to rethink that, because that is a huge networking opportunity that you're losing out on for sure. What I like to think part of the reason I got recruited to Columbia is Chris Visco was one of my like far away mentors. I'd never actually been his student or his resident, but I met him at an AIUM conference when I was a second year, and we kept in touch, And so things, academic medicine, it matters some of those ties that you have, because people want to work with others that they get along with, that they see at these conferences, that are interested in the teaching opportunities. So that's definitely something that I would want to do if I were you. And then obviously trying to do your fellowship at an academic center is going to help you too. There's a lot of fellowships that are private practice based, and they're great, but if it's a different way of working, it's a different, they're not the same. They don't really mesh very well. So yeah, that's what I would probably do.
Yeah, for sure. And Sheena and I say this a lot, and I cannot stress this enough. If you cannot go to these conferences, volunteer to be an ultrasound model. I'm like, hi, Jonathan, nice to meet you. I'm like, I'm scanning butt. I'm like, yeah, Benecia, yep, go ahead. You'll get very close with this, everyone who's scanning you.
Exactly.
Find out who was hosting the conference. You email that director, like, hey, when it opens up, I want to be a model.
Absolutely.
And they will be like, okay, perfect. Yeah.
Absolutely. Yeah, we love it, because you're all excited to learn, and it's just, I don't want to be the model. I'm trying to scan. So like, let's bring you in, and it's a great opportunity for sure.
All right, here's another question. Hader says, thank you for your time. I was wondering if you could possibly speak about your experience with the residency program at Mayo and how it has prepared you for your current practice.
Mayo has a very wonderful place in my heart. It's so fun because I'm so not a small town person at all. So, I lovingly call it Roch Vegas completely as a joke, but it was the training for what I wanted to do. There was not a better place that I could have gone. I did a rotation there as a med student for, I think 2 weeks, maybe a month. I can't remember. And it was a great experience. So if you do have the opportunity to do that, I know that's not really an option this year, but if other people have the opportunity to do that, I probably would if I were you, because again, they want to make sure that you kind of fit in with the kind of the Mayo way of life a little bit. But the training is amazing. And the best part is none of the clinics at Mayo, and this is true for a lot of residency programs, but none of the clinics require you to run. Meaning that you are there to learn, not to scut. You are there to learn, not to write notes for somebody else. Now, you are going to have to write notes because you learn like that, but you can kind of tailor your training a little bit as needed. And for me, that was great because, I knew I didn't want to do SCI or TBI. You still have to do those months there, but on the months that I was on outpatient, I got to really tailor that into what I needed. And I could kind of hang out with Grog one day, Wisniewski another day, Smith another day, Selin a different day. And I even was able, this was when John Finoff had just started up at Mayo Clinic Square up in Minneapolis. And I even drove up there and hung out with him a couple of days because for what I wanted to do, FinOff was probably the closest person to what I wanted to create into my practice. Right. Yeah. But it was awesome. They're very supportive of their residents. They do not overwork you at all. Which makes you maybe a little slow when you get into practice and you're like, shoot, I have to write notes much faster than I was before. Yeah. But the education is awesome. The only thing I will say is that because it's Mayo, it's like a tertiary, quaternary center. So you're getting people that are asking for second, third, and fourth opinions. So they come with these charts that are like this. So you're not seeing the bread and butter necessarily. Like seeing an ACL, you're like, oh, damn,
right.
You know,
like, oh, this is,
but like I saw Creutzfeldt Jakob. I can't even tell you how many times. Like, who sees that?
Yeah, right, exactly.
You know, so it's cool. It's definitely different. I would not trade it for the world. I am so glad I trained there for sure. You know, would I have stayed there? I mean, maybe, but at this point in my life, no. But for you can go anywhere for a couple of years if it is worth it for your training. And honestly, if you think that's kind of the realm you want to live in, check it out. It was awesome.
Yeah, for sure.
Yeah,
totally agree with that.
I think, you know, you keep stressing this, but no matter where you end up in residency, the key is if you know what you want to do, be proactive, seek out those opportunities. Yeah. Like, you know, if you have to drive 45 minutes, an hour, you know, for 2 weeks, do it. Like, yeah. And
residency is going to have everything you want, right? I got very little dance exposure when I was a resident, but I already knew I wanted to do that. And I figured it out, tailor. You know?
Yeah, exactly. And I think that's another good point you brought up is Sheena and I, we're all very much, I think, like-minded individuals. And we went to programs where we were going to learn. Like this program would be still going on if the residents weren't here. Like is their job. So you're there, we are one-on-one and we're strictly there to learn and not to run the service for someone else. So I think that, but some people learn better like that. So, you know, you just have to figure out how you learn best, and that's fine if you do. But I think knowing that going into residency interviews is very important to know how you learn best.
Yeah. And like you're interviewing the residency program too. So don't like try to fit into their mold. Don't do, you will be miserable if you do that.
Absolutely. Yeah. Absolutely. Agree. And I went to, I never thought I would end up going to Rochester other than my oral boards, but I went to the Mayo Clinic, the sports medicine board review before I stepped for my boards. And it was great. It is amazing. Even if you aren't taking the boards and you just want to go learn and get some CME, it is a great freaking
it is awesome.
It really is.
Yeah.
It is.
Yeah. I know. Totally agree.
Well, yeah. Anyone else have any questions?
Any other burning questions, guys?
I told Rachel yesterday, and I said, well, I'll have to go to the Ironman conference. I said I met John Finoff there, and then I like the next week we're at the AA PM&R. I'm like, I'm not following you, I promise. I'm not stalking you. He's like, I just saw you
stalking me
in Kona.
Yeah, they're great. I love those guys. I mean, I love them very much, and I'm so happy I had them as mentors. But like, oh man, we need more women in sports at that level, because like Joanne Borgstein's been like holding the fort down for a really long time by herself. Oh man, God bless that woman, you know? So, you know, it is a boys club still, but yeah, I'm working on it. I'm trying.
And I think you have the personality for it. And you brought up imposter syndrome. And I was telling my friend Ugochi Asweka, she's an expert in regenerative medicine. And that's what I have to tell her. I'm like, Ugochi, you are an expert. You spent a whole year in fellowship in Colorado just to learn Regenex. I'm like, you have to own that and know that and support and market yourself like that, because you're a big deal.
Exactly. Exactly. We're just, you know, we tend to try to shy away. We're like, well,
it's okay.
Own it.
Yes.
There you go. All right, Sarah, one last question from the audience. So any networking tips while at conferences? So especially if you're more like introverted, you know, not as outgoing as Julianne, Benecia here, you know, what
you find a friend, that is.
So a couple things. So number one, attending a lot of the like little lectures that are put on by 10X or RegenX or whoever. You're going to meet some of the experts in the field just because they do consulting work for them, right? So going to those, and it's free food, so go. It's easy. Going to those is a great opportunity. picking a couple lecturers that you think have a practice that you really appreciate, or a way of thinking that you appreciate, or something that you're very interested in, and go to their lectures and then speak to them afterwards if you can. Don't follow them around and don't stalk them. And generally speaking, a lot of sports medicine people are very social. So if there is a social event that you can go to, go. But don't talk to them and be like, so what do you think about like PRP for, partial thickness tears of the peroneus brevis? I don't want to talk about that right now.
Right,
right. Let me get to know you.
Right.
So that was my big thing. And I think that's why I had an easy time, for lack of a better word, schmoozing with these guys, is because I was just normal. I was just like, let's shoot the shit. Let's hang out.
Just be yourself. Yeah.
Exactly. But like, don't be like, we don't like brown nosers all that much, I guess, in a way, like we want you to be smart. Don't get me wrong. But like, if everything you talk about is talking about medicine, that's awesome. It shows you're interested, but it also kind of pulls us down a little bit. Cause like when you are done with the conference and you're just trying to have a social hour, you want to socialize. And so being able to realize that is helpful. If you are more introverted, then coming through with some really good questions and then sending an email afterwards, even just so that they recognize your name, can be really helpful. And then say, hey, I love your lecture that you gave on XYZ. This is some stuff I've been thinking about. Is there any way I could come shadow you for a day if possible? Like whatever. Like a lot of us will take you to come shadow for a couple of days. It doesn't bother us at all. So that would be the other thing if you're not great in big groups.
That's excellent advice. Yeah, be very strategic. Even I remember being like a PGY 2, 3, and 4 and planning out which conferences I was with my conference money, like each and every year. I'm like, this year I'm only going here, but I'm going to go here and do this. And then and when you get the conference book, you're like, okay, I got to go to this lecture here, and get some face time. We got to go to this residency fair or the job fair. So you got to be strategic.
Yeah. And find, like, you might not know your niche yet, but if there is something that you think might become your niche, like find the people that work in that world, because those are going to be the ones that are really, driven to talk to you about it. Because they'll be like, oh, you like what I like? Cool. Let's be friends, and then if they have social media, follow them on social media and, show some interest in what they do.
Yeah. Yeah. In physiatry, we're small, but we are out there on social media. I think we have one of the supportive specialties out there. So
med Twitter's been like on fire with physiatry. I'm so proud. Or that's all I follow. I don't know, but but it's maybe amazing. That's all I don't know, but it's been good. Yeah.
All right. So our last question we ask all our guests, before we end our session here, is if you weren't a PM&R physician, what would you be?
Ooh. So if you would have asked me that like 10 years ago, I'd say probably a professional dancer. My knees can't be professional anymore. Honestly, I think I'd probably work in marketing in some way, shape, or form, or work in the media. Like I actually, my very small time that I've been on TV, like it's actually kind of fun to be like a media correspondent. So I feel like maybe I would have gone into media because, again, I really like talking and interviewing people and talking with people and learning stuff.
And you should do some more. You should, because like when sports come back, like you should be the face that when people have injuries, they should come to you and talk. And
that would be cool. I think I will. Yeah. Hey, ESPN.
Holler at you.
Or NFL Network.
Right, holla at her. Yeah. I need to connect you with Jessica Shepard. She's an OBGYN, but she's been like on Good Morning America. Like she's correspondent. So I'll
medical correspondence is really fun. So I've actually really enjoyed it. So I think that's fun. And even just like doing those butterfly videos, like that was so fun for me. Yeah. They flew me out there. We did a couple takes and stuff. And I was like, it's very sweaty in these lights, but whatever. And it was fun. And it's a cool way to teach. Because you're teaching the masses, you know what I mean? You're not just teaching one or two people. And so that's really enjoyable for me.
Very good.
Well, so you mentioned, social media. So if anyone has any specific questions for you, how can they get a hold of you?
So I check my Instagram every single day, for better or worse. So Columbia Dance Medicine is my IG handle, and it's COLUMBIA Dance Medicine, all one word. So that's fine. My Twitter is at the new Dr. J, like Dr. Julius Irving. Little shout
Like
out
that.
to him.
I noticed that. I like it.
Yeah. Yeah. And then otherwise, like you can give people my work email, I guess, which is totally fine. Just sometimes I don't answer it very often because, you know, you get inundated with emails all the time. I don't know about you guys, but I get like 100 emails a day now.
Yes.
I'm like, why? How did I get all these?
Famous, that's why.
Yeah. Oh yeah. No marriage proposals, please. But yeah, probably my Instagram or Twitter are the best way to get a hold of me, and just send me a message. And anybody who wants to talk about mentorship, I know like this year it's so hard for applicants because they're like, I can't go rotate anywhere. So if you want to talk about stuff, I am happy to do it. If you're a foreigner and you need advice, come talk to me. I've been through it all. Like I will, I got you.
That's huge.
Yeah.
Because we get these questions a lot too, so we can definitely
I'm happy to, because I wish I had somebody to kind of tell me what to do, but you know, I didn't, and it was, you know, a lot of
difficult.
Oops, you know, don't get deported. That was like my little dance the whole time. Yeah.
Okay, well, thank you so much. I'm sure everyone out there will appreciate you being so open and willing to help. So we appreciate you coming on today and joining us. It was a pleasure.
Thanks for having me. It was fun.
And you guys can always, you know, follow us, Virtual Physiatry Mentors. We are on Facebook, Instagram. We have our YouTube video. So if you missed the earlier parts, if you want to watch the video again, we will have those on YouTube as well. And Hayden's been helping us with our podcast. So we are now on Spotify and iTunes. So
we'll post those links. Yeah, it's all on our link tree on our Instagram. So.
Yep.
So yes, be sure to join us next week. We'll have Dr. Chris Williams and Dr. Ugochi Ezwike. They are experts in regenerative medicine and do a lot of different procedures. So they're just gonna come on and talk about that. So we'll see you guys next week.
All right, thanks for tuning in.
Thanks. Bye guys.
Bye.